This conference will now be recorded.
Good evening, everybody. It's John Antonucci. This is AnCan's high-risk metastatic advanced prostate cancer discussion group for May 27th. We'd like to thank Bayer and Johnson & Johnson and Myriad Genetics, as well as Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis for some of the support that allows us to put this on. I think I'll go. Who said they wanted it? Was that John that was going to? Oh yeah, you got your hand up already. Go ahead, John, and then I'll get on my list.
Hold on a second, John. Let's just say a word about people leaving early today.
Oh yeah. If I even make it until 2 hours from now, I will leave abruptly a few minutes before the hour, and Rick will take over so that I can sit in on the veterans speaking freely group.
All right. And if anybody else who's here, who's a vet, can move over to the veterans speaking freely group, please, by all means, leave a few minutes early and then just head over to the Schmier room. That group will open. Well, the room will be open probably when you move over, but they'll start their meeting at 5 o'clock with Bill Franklin and Boykin Jordan moderating that meeting. If Dr. John's feeling okay, he'll be sitting in the background. So, and I think Dr. Schhelhammer snuck in right under the 10-minute rule. If you want to check with him, Dr. John.
Hi, Paul. How are you?
It's a challenge to get in. I still have. I start 10 minutes early. It belies my age. but wish to also say there's a PCF Foundation webinar. I believe it's 7 with on hormone therapy. So I am going to try to see if I can make my way into that when the time arrives.
Okay. In the meantime, do you want to bring up anything of your own?
No.
Okay. And how about you, Jerry?
No, I'm fine.
You're good? Okay.
Thank you.
I got a couple hands up already. Even now, just clarify for me, is this something you guys want to mention before we get rolling down the list, or are your hands up because you want me to add you to the list one by one?
Quick comment before we begin.
Okay, that'll be fine. And then who else had their hand up?
Dr.
Joel.
John, I'll volunteer to go to a small report.
All right, very good. Okay, go ahead, John.
I'm going to volunteer Rick to reach out to an 82-year-old ex-president and invite him to the group. I want that just so I can sit and listen to Dr. John do the intake interview. That's all I got to say.
Yeah, I guess we'd love to do that. We've been through. I've sort of been through the ringer on this the last week and a half, including up till today, when somebody I've been talking with again came back to me and again said to me that my questions had nefarious implications. I don't get it. I don't get why this particular person is not willing to hear the same questions that I'm asking from people like Larry Klotz, Peter Carroll, Scott Egner, Mark Schultz, Kurt DeVille, and I mean, I could just go on. And, they're writing to me and then telling me, don't be defensive when you write back to me. And, I'm not being defensive. All I'm saying is we're asking the questions that need to be asked. We're not suggesting what the answers are. Who knows? I mean, who was it who said to me today? Oh, I remember what it was. Somebody said to me today they saw Biden walking and he walks like a friend of theirs who has Parkinson's. I don't know. All I know is his health wasn't 100%, and nobody came up and said his health isn't 100%. And that's what we're saying. And if that's considered to be nefarious, if that's considered to be conspiratorial, what they need to do, those people who are accusing me, is go ask the doctors why they decided not to tell us. What was the reason?
Well,
So
I just want interest. My interest is in his prostate cancer story. I'm being very serious.
I'm sure.
Yeah. So
I'm sure. And for the record, from our standpoint, and I put it out now as a blog post. It was in your reminders if you read it. But our position is that all men, no matter what age, deserve a PSA test. Now, what they do with the results should be done with shared decision making with their doctors. But because they're over 70, doesn't exclude them. It particularly doesn't exclude them if they've got a BPH history with a high PSA, which is what Biden had. So somebody was sleeping on the switch. Either
it's an important message to get out. It's an important message to get out.
Either the doctors chose not to test him with his consent, or the doctors missed what was going on, or they chose not to tell us. Those are the only three things I can see. But we are all in favor and promote continued PSA testing, no matter what the age, even if you've only got 2 years of life left, and then sit down with your doctor and let the doctor and you decide how you want to treat that. Because PSA testing is about information. It's not about treatment. And if you don't have the information, you can't make the right decisions. That's how we see it.
Really important message. Love it.
Hey, Rick, this is Jim Ward jumping in by phone. I think I heard you say that Biden had a confirmed high PSA result, but I don't know if we know specifically what it was at any given time. I haven't come across that, so I was just curious if I heard you right, and if we know, what his high or elevated PSA result was.
Okay, it's not exactly what I said. What I said was
okay.
Biden had BPH.
Okay.
That's what I said. We don't know what his PSA was because they didn't release it. But what they did tell us was that when he was 69 or 70, he definitely had a high BPH, and that in 2019 he had treatment for BPH.
Okay, got it. Thank you.
There's also a video out there where from 2022 where he says he had cancer. He doesn't say what kind, so I don't know if it was prostate or some other cancer, maybe a skin cancer, but he did say that. And did anybody else see that video? Yeah, Don Rogers, yeah.
The thing that throws me most of all is how does anybody know he's sensitive to hormones?
Well, you're absolutely right, Dr. Jack. And that was one of the first things that I said right at the beginning, for which I got accused of being conspiratorial. No. They could have said, we hope he's MHSPC. We hope he's MH, but not, that he's a MHSPC. They didn't know at that point in time if he'd just been diagnosed. There had to be time for him to respond, and I have that in writing. But you know, it was not right to say he's sensitive to hormones. We don't know, but maybe they do know, and maybe that was because he's been on them for longer. I don't know, but I was responding to what I was hearing out there, and for those of us who are educated around this subject, Dr. Jack picked up exactly what I did. You don't know if somebody's MHSPC with metastatic de novo prostate cancer. They may take the drugs. They may take the drugs for 4 weeks, and their PSA may start to rise, and we've seen that. You just don't know. Anyway, John, I think we should get on with the meeting.
Let me just make sure Joel has had a chance to say. Did you want to say anything, Joel?
Yes, I can give you a report.
Joel needs time.
Oh, about yourself. Okay. Very good. I will get to you then. I did hear something obliquely related to politics, which is good news. About 5 or 6 days ago, the World Health Organization released a rather sweeping consensus statement about dealing with pandemics. And I think that's very good because we really weren't well prepared for the last one. And they did the whole thing without the United States being involved at all because we're not a member of WHO anymore. But I thought that was good news for the next time some virus comes around. Stephen, let's see. There you are. No picture. Stephen, you had a number of questions, right?
It's John. Thank you. The first one is, I'm wondering if anyone can comment on whether a biopsy of the prostate risks spreading the disease either inside or outside the capsule.
I think the answer to that is no. Does anybody disagree with me?
I always thought about that when it happened, when I had my biopsies 22 years ago. How do we know it doesn't?
Has anybody proved one way or another whether it's possible? Not that I know of.
I'd like to defer to Dr. Schhelhammer on this one because the common wisdom has always been, and I think there have been, in fact, I'm sure there have been trials. I remember seeing them years ago, like, well, not years for me, not years for Dr. Paul. Like I'm talking about 2010 on research that the biopsy process doesn't cause the disease to spread. Dr. Paul, what is the wisdom on this?
Well, interesting question. About 10, maybe 15 years ago, a incredibly expansive review of the tens of thousands of biopsies came up with, I think it was 7 or 8 instances where there was a perineal nodule, because the biopsies in those days prior to transrectal ultrasound, which makes it difficult to monitor this issue, but when they were transperineal with a Vim Silverman needle, there were fewer than 10. I'm going to say 7 or 8 out of hundreds of thousands of biopsies. You know, it was kind of one of those articles in the literature that said, yes, it can happen because almost everything can happen at least once, but it's just extraordinarily rare. And these were nodules that were confirmed to be prostate cancer in the perineal area where the Vim Silverman needle had entered. So again, this was primitive needle, large bore, hand delivered. Recently, now that transperineal is coming back into the forefront, perhaps we'll see a rare case here or there. But of all cancers that I'm aware of, it's the least likely to track a biopsy.
Thank you. Stephen T, does that satisfy you? I should add, since you probably don't know, Dr. Schellhammer is a former president of the AUA and a career urological oncologist.
Yes, thank you. Thank you very much.
They said the
Let's-
same thing at the PCRI, by the way. The question was asked.
Oh, thank you.
My
What else
second
is that,
question
Steve?
is brachytherapy contraindicated if the Gleason score is 9?
No.
Absolutely not. Go ahead, Dr.
No.
John.
I would say no again, unless Paul has another opinion.
Go ahead, Dr. Paul.
Well, I think it's unusual to use it as a solitary therapy. It's usually, in my experience, an adjunct to external beam. But, I'm sure that there's no contraindication to such, but I think the usual plan is to use it as a ancillary boost to usual current external beam delivery.
Yeah, and I'd absolutely endorse that. I think Dr. Paul is spot on. In fact, for many, many years, the gold standard was for very high and very high risk treatment was some type of brachytherapy, either low or high dose, together with IMRT across the pelvic girdle and hormone therapy. So it was used all together. It would not have been used alone in a Gleason 9, 4+5 or 5+4, but it was certainly used in adjunct to the IMRT or the plus the hormone therapy. That was the treatment that I got, Stephen.
Thank you. My third question of 5, I've heard.
Well, hold on. I don't know. We got time for 5. Let's.
It's an unusual night.
Right. So you may be able to hold them to the end. Hold your other 2 to the end.
I'm almost sure we'll be able to get back.
And we'll probably be able to get to them at the end, but we want to make sure we get round everybody. So pick out your next most important question and then hold the balance of the questions, please.
Okay. I've heard conflicting information about whether the internal sphincter is preserved during a radical prostatectomy, not in this group, but elsewhere. So I was wondering if anyone can provide a definitive answer.
This is so great that Paul is here. He'll probably never come back again. But would you explain to us, Paul, about the internal and external sphincters and what you have to take in a radical prostatectomy and what is left to us to work with?
Yeah, well, that is a delicate question because the distances that separate the prostate from the external sphincter and the internal sphincter are millimeter marginal. So the external sphincter is a voluntary muscle that surrounds the prostate right at the apex or just distal to it. And, it's something that you can visualize and control by starting your stream. The internal sphincter is your kind of hold on to it mechanism when you're just walking around and your bladder's half full. You're not contracting your perineum and voluntarily keeping yourself continent. That internal sphincter tone is what does that. And it's interlaced to the bladder neck in a rather complex interdigital way. So, the difficulties with preserving it entirely is that do you leave some prostate tissue which is abutting it? And are you doing an incomplete radical prostatectomy? And does your PSA not go down to undetectable because there are some either benign or maybe unfortunately malignant cells still in the area? So yeah, the presumption is that you can preserve a good majority of the internal sphincter, but the variable continence of individuals after an identical procedure. You know, docs say, geez, I did my best operation and the gentleman is incontinent, or he says, boy, this was a rough go. And voila, 2 weeks later or a month later, the patient says, gee, I'm doing fine. So that's a variable that is, as far as I'm aware, increasingly difficult to define definitively when you're doing the surgery, whether it's robotic or open. But welcome other folks' ideas.
Dr. Paul, I just want to say how much I appreciated that answer. That was beautiful. I had the experience of having mine preserved. Fortunately, I was in the hands of an excellent surgeon, Peter Scardino, and we went through that whole process. And you know, a very skilled surgeon, if I don't have cancer in that particular area, is able to do a good job and allow me to remain, you know, continent. And I was fortunately in the hands of a good surgeon.
Wow.
Thank you.
You're muted, by the way, Dr. John. I don't know if you knew.
I didn't know I was muted. Thank you. When I start coughing, I hit the mute button and I forget to unmute myself.
Yeah, okay. You have a couple of questions, people with questions.
Stephen, I was going to get to you next. Let's see what you had. You have your hand up, Stephen? Steve?
Yeah. Yes. Couple related items to Stephen's questions. One, the brachytherapy, many people think it should be contraindicated by prior TURP, but from my experience, Gleason 9 wasn't a factor. And the spread of cancer through a biopsy, I had a TURP following the discovery of my cancer. And several months after the TURP, I passed some TURP chips, which made me question whether the cancer could be spread to the bladder wall by the TURP chips. And I was told that it was not a way that the cancer was typically spread, but I don't know if that is, you know, a common understanding or not. But yeah, that's the only two little additions I had.
Thank you. Len?
Yeah, thanks, John. I'd like to continue to pile on Dr. Paul here. Just one more question. It seems like nerve-sparing surgery for prostatectomy to preserve erectile function is a fairly recent phenomenon that we started hearing about maybe 10 years ago. How real is that, or should I say, how difficult is that to actually achieve?
Well, it is real. And the comeback days past was it was a cancer sparing operation because the separation of the neurovascular bundle from the capsule is we're talking about millimeters of distance. And under just the eye, the naked eye, difficult. Then with microscopic vision and robotic amplification, a bit more likely. And now there is, just as an aside, interesting information, again, using large language data management to look at the PSA, the Gleason grade, the PSMA scan, an ultrasound with the exact view, and just have a whole bunch of data points that are learned, and that when you direct whatever instrument you have, and this is space age and not yet available, but the hope is you will get feedback as to whether or not the area you're dealing with is likely to have cancer or not, so you can be more nerve sparing and we'll say capsule preserving. There's also fluorescent possibilities with regard to PSMA scan, so that you actually see a bright light, so to speak, where cancer is, and you can avoid it. So this is pretty high tech stuff, and everybody's nerve bundle is different. And when I first started nerve sparing, I said, I don't know what I'm seeing. I'm just kind of going by a pattern from Johns Hopkins. And that's how progress is made, trial and error a bit. But I'll say now, a good surgeon with the robotic visualization should be able to do a safe nerve sparing most of the time.
Thank you.
Gary?
Thanks, John. I was just wondering, when I was diagnosed with Gleason 9, brachytherapy was never mentioned as a possible treatment, and I haven't heard it widely discussed as a possible treatment for Gleason 9, and I'm wondering if that's an accurate perception on my part, and if so, why has it somewhat fallen out of favor?
I would say it's not an accurate perception on your part, Gary, with the greatest of respect. I think that it's long been mentioned. I mean, I was diagnosed in 2007 and I started my treatment in January of 2008. And it was certainly on the table at that point in time and considered to be, even then, most likely the gold standard. Now, the open question was, should it be low-dose brachytherapy with the seeds that are implanted, or should it be high-dose brachytherapy? And even around the high dose, even then, there was more than one way of administering it. Most people at that time did it in 2 sessions a week apart, although there were very few people that did it in 1 session. And the high dose, they insert the rods and then they pull the rods out, so nothing gets left inside of you. Now, at that time, as far as I know, and please, Dr. Paul, correct me if anything I say is not right, the high dose tended to be used for bulkier cancer in the gland. So if you had a lot of cancer in the gland, they would recommend high dose. If you didn't have very much cancer in the gland, they would recommend low dose. Low dose at that time was also used for men who had 3+4, unfortunately, even some who had 3+3, and sometimes 4+3s as well. As Dr. Paul correctly pointed out earlier on, if you had more aggressive cancer, 4+4 or higher, it would be, if you were going to do Breaky, it would be combined with some sort of external beam to other areas in the pelvis, maybe the prostate bed. I was a patient of Mac Roach, who was very much in favor of radiating across the pelvic girdle, which is what he did to me, for me. So, I mean, but you can track it back, even in the literature, you can track it back. And we've always said in this group that we strongly recommend. Now, what I didn't say to Stephen T before, it crossed my mind and then I forgot to say it, is that some of the practitioners who used to use high-dose Breaky prefer today to give that boost through SBRT, stereotactic body radiation therapy. So they don't use Breaky at all. What they'll do is give a couple of SBRT shots to the gland. The protocol, I think, is 4 treatments, if I remember correctly, although people like Mac only use 2. They feel that it can be done with 2, and he actually spoke about that at PCRI.
So when I was considering options, the rad-onc I talked to should have mentioned brachytherapy.
Yes. What year was that?
2020.
Absolutely. Did he talk to you about SBRT plus IMRT?
Oh.
Yeah. So yes, he should have either talked to you about Breaky plus IMRT or SBRT plus IMRT with a yes. That was I would say that was an error on his part. That's my view. I think most educated commentators would say the same thing. It should have been mentioned.
Thank you.
Let's go to RJ. See what's on your mind, RJ.
Dr. John, just one thing. I sent you a note. Could you please raise me to an organizer? I came in not as an organizer. Thank you.
Yeah.
And then I'll take care of Len and anybody else.
So I have a few updates. So I reached out to a few people. I reached out to Dr. Westphalen and at these are people at University of Washington, Fred Hutchinson, and he said, "Well, I'm a radiologist, so I can't recommend therapy, but it sounds like if you get into this multidisciplinary clinic, that's one of the best ones in the country, so that will be the best place to go." So that was his feedback. And then I also reached out to Dr. Schweitzer, and he said pretty much the same thing. He said, I mean, not that he's a radiologist, but he's a medical oncologist. And he said, well, you'll talk to a medical oncologist when you go to that multidisciplinary clinic. So if you have any other questions or you need any help, certainly I can help, but that's going to be your best bet is to go to that multidisciplinary clinic. And then I also today just reached out to Dr. Lynn, who's a urologist at UW. And I didn't mention the multidisciplinary clinic because I just said, hey, like, my urologist said that I should get surgery. He referred me on to another surgeon, but, I would like a second opinion on that. So, and I haven't heard back from him yet.
When you say the multidisciplinary clinic, are you talking about Fred Hutch or a different place?
Fred Hutch, yeah.
Okay, yeah, I thought. Okay, thank you.
Yeah, so that's the update on that. On Thursday, I had my PSMA PET scan, and so I just got back the results from that literally at 3 minutes to 3. So I kind of opened that up and I thought, well, like what better place to have support than to open it up and read it. And I mean, I don't know exactly what all it means, but I think it's not.
I think you should go ahead. We have time. Go ahead and read it if you like.
Yeah. So it says, it kind of goes through and it talks about a bunch of stuff, and then it gets down to the pelvis, and it says, that essentially like they found the radio tracer in my prostate, which is expected. And then the second item is the focal radio tracer accumulation within the two normal left external iliac lymph nodes is highly suspicious for tumor spread. And then the third one is right seventh rib metastasis. Suspects patient also has left seventh rib, posterior left iliac wing, right sacrum, and right pubic symphysis skeletal metastases.
Okay.
So I don't know how bad that is. It sounds like it's something.
Yeah, well, this will be very helpful in guiding your treatment, and it'll lead you into more body treatments than purely prostate treatments, right?
Yep.
You already had, let's see, I'm looking at my notes. You did have some lymph nodes. Oh, no, you didn't have lymph nodes on the MRI. Now, that's interesting.
No.
So your MRI missed these 2 lymph nodes. When it listed these various findings, did it give you an SUV or any kind of indication of the intensity of the signal?
Not that I can see.
Because it sounds like they hedged a little bit on some of them.
Well, there's one in here that says there is focal radio tracer accumulation within 2 left iliac lymph nodes. One of the lymph nodes measures 1.6 by 0.7 centimeters.
Okay, so that's not probably 2 lymph nodes. That is 2 iliac lymph nodes. One definite rib met, one maybe rib metastasis, and then some other ones that they hedged a little bit on. Right?
Wasn't there a sacrum and something in the pelvis too, RJ?
Yeah, it said suspect patient also has left seventh rib, posterior left iliac wing, right sacrum, and right pubic symphysis skeletal metastases.
Okay.
So, my iliac wing, sacrum, iliac wing. Where was the other one? Sorry, I'm just typing as you're saying.
The left and right seventh rib.
Right. Okay. Right. So iliac nodes, the right sacrum, the iliac wing, 2 spots on the rib. Anything else? Was there something on the hip?
No.
Oh, pelvis. Okay. So.
Did you say scapula?
No.
No.
No. Yeah, lungs and everything up from pelvis. Pretty much nothing.
Okay, so this is very tricky because if I'm counting right, you've got 2 on the rib, iliac wing is 3, right sacrum is 4, and the 2 iliac nodes, which is 6. So I think what I might do is, well, there's a couple of things. First of all, I think I would definitely go back to Swedish and ask them for the SUVs. They should have noted the SUVs on there. I think it's really, really important. It's going to be very helpful, and it'll help whoever makes a decision. Okay? The second thing is you are no longer a candidate for surgery, almost certainly.
That's good news, I guess. I don't have to worry about that.
Well, that's if you like the good news. The bad news is that given your age, given the fact that you've got 6 spots, you may be a very good candidate for chemotherapy. And you may do very well if you have early chemotherapy. In addition, you are a candidate for hormone therapy plus a second-line anti-androgen, ARPI. Most likely, the protocols suggest abiraterone unless you have adverse comorbidities. And I think what I would probably do right now is write back to Dr. Schweitzer and say my PSMA scan seems to show at least 6 spots, and I will get you a copy of it. We're checking on the SUVs. Can I come in and see you as soon as possible rather than going through the process? Now, going through the process of the multidisciplinary. Now, many men today, and this is really a development in prostate cancer treatment, many men today will at some point, if de novo metastatic like you, they will get their prostate treated with radiation. But it's not usually right at the beginning. You'll hear the expression debulk, and debulk normally means that the radiation oncologist goes in and they radiate that tumor, and they may radiate across the hips. It depends on across the pelvis. It really depends very much on the radiation oncologist, because some think that does harm, others think it does no harm. My own personal opinion, I'm not a doc, but I would always take that, largely because it worked for me. So that's the only reason I say that. But I think that you need to get into Dr. Schweitzer's care as quickly as you can, and then with Dr. Schweitzer, walking down the road after you've done some treatment, decide on how you want to follow up, and keep in mind that at some point, maybe a year out, that you'll want to get you'll want to get your prostate treated. Steve L., you associate very well with this diagnosis, do you not?
Yes, I do. I was Gleason 9 with lymph node mets and 2 bone mets. Couple of comments for RJ. One, on the disciplinary team, if you end up going that way, I would try and get Schweitzer as the GU medical oncologist on that team, and not some person that you don't know and doesn't come highly recommended. So yeah, the idea of avoiding the team or following it up later might work. There's also one trial that might be appropriate to you, the SWOG 1802, which would allow you to get radiation or surgery early on, even though it is not the current standard of care.
Mm-hmm.
You might want to consider that.
Mm-hmm.
What was the name of that trial again?
SWOG 1802.
SWOG. Okay, got it. Thank you, Steve.
Yeah, we've had a guy who did the surgery, I believe, in that trial several years ago. If it were me, I wouldn't go near the surgery because it's just a whole bunch of additional comorbidities. But it might be interesting in discussion with Dr. Schweitzer to consider the radiation early. That I would recommend. It's definitely worth a discussion about the radiation. But I think that once you go back to Dr. Schweitzer and say, Dr. Schweitzer, I've gotten my report, or you send him your report and I'm trying to get more information, can I come in and see you ASAP? You'll find him very, very receptive.
Okay.
Now, if for any reason he can't take you, I would say either Larry Fong, if he'll take you, which you can't do better than that, but I don't know if he'll take you because he's only seeing very special patients like Steve L. But he would be fantastic. Heather Chen would be also very, very good. And we have guys who see her and they really like her. And she's very nice and very, very smart. So I think that as long as you see one of those three, you'll be in very good hands. Larry Fong, Heather Chen, or Mike Schweitzer.
This is, I think, really a nice time for somebody like you, because a mere couple of years ago, you probably would have gotten inadequate treatment. And I think now you'll get a nice intensified treatment that more matches the fact that you have these metastases. Now, on the very off chance that you might be carrying a BRCA mutation or something that might affect the choice of medications, I think it would be good for you to get a somatic gene test as well.
Okay.
The doctor that did the biopsy has to send biopsy samples for a somatic gene test.
Right. And it's funny, John, you were reading my mind, because I was going to come back in and say, make sure they test your tissue. With doctors like Chen or Schweitzer or Fong, they are all so committed to being aware of your mutations that I'm sure that they would all follow it up. And I would get the somatic test, and then depending on the results of that somatic test, you may need a germline test to see if those mutations, if you have any, were inherited or not. But when you get that somatic test, it will give you the answers, but it won't tell you if they were inherited or you made them. You'll have to follow up with a second test to find that out. But here's the good news, okay? Because this is an awful lot for you to absorb. The outlook for people with your diagnosis today going in healthy is way better than it's ever been, okay? We can't really tell you what the prognosis is, and the doctors will give you numbers, but we don't particularly love it when the doctors give you numbers because they don't know, okay? One thing we know with you is that you're getting in there really early, which is a good thing. Your PSA is going up, but it's not going up crazy. We didn't find you with a PSA of 1,000, which we have plenty of experience of. If we found you, God forbid, with a PSA of 1,000, maybe the outlook wouldn't be quite as good. So there's lots and lots of reasons to feel that you can be treated for a long time with several lines of treatment, including a whole bunch of even know because they'll be emerging. So would Len or John, would you want to comment on that for RJ?
On what, emerging treatments?
Well, on what to expect and how to deal with this.
Well, what to expect, and then I'll defer to Len on this, is that you'll probably be put on hormone therapy, intensified by abiraterone or some androgen receptor pathway inhibitor. And you probably will be considered for chemotherapy called docetaxel. And it probably radiation won't play a big role early on, I don't think. So we've got people here who've been on all those medications. And so if this does come to pass, you can talk to us about coping with all that as in the near future. Linda, can you contribute to that?
Couldn't add anything to what you said, Dr. John. Perfect, in my opinion. We do have Bob Schwarz on the call, I believe, who has not a dissimilar case. You know, he's on triple therapy right now, and I don't recall how high his PSA was. Not quite 1,000, but I think it was pretty high. Denovo metastatic, and I don't know, Bob, do you care to comment at all on how you're responding to your treatment?
I will tell you, doing the triple therapy was the best decision I made, and I appreciate all the information I got from AnCan and other places. And also the doctor you got to go see. The doctor you pick is your quarterback. You have to have confidence in them and take their word of what they're doing while you also come back here and ask questions. The triple therapy has been good. The hardest part has been the chemotherapy, honest with you. I'm 69 years old, and I can tell you why most people quit after 4 treatments of chemotherapy. 5th and 6th, even though it gets progressively worse, 5th and 6th were the worst I've ever went through. But they also benefited me. My PSA has dropped from 322 down to 0.2.
Wow.
All right, Bob.
All right,
So,
Bob, that's great news.
Worth it. And there's a lot of things you got to go through, but they ask the group here, the comments you'll get, like maybe red blotches, you know, the hydrocortisone cream you might have to use for the spots and things like that, and other things you'll go through. But there's a wealth of support with this group. I'm telling you right now, I wouldn't have been able to do what I'm doing without this group, and I thank you wholeheartedly.
God bless you.
Thank you, Bob.
Oh, and also last but not least, my lymph nodes, which were out of whack completely, have all gone down the normal range now. So I'm doing good that way. The only thing I'm still addressing is the metastatic. And unlike you, it had only 6. I had innumerable in my PSA scan. So it was a little bit more than yours, I'd say.
All right. Well, sounds like I'm in the right place, and I'm in for a bit of a fight, but that's okay. I will do whatever I can do. So, I mean, sounds like I've gotten a little bit unlucky. That's okay. But I will make the best of it and do the next indicated thing. And super glad that I found this group kind of in the nick of time. I probably would have found it eventually anyway, but it's perfect to have landed here last week before this, and then also like literally while I was already on the call, got this report and opened it up and read it and said, well, you know what, I'm in the right place. I'll do whatever I'm supposed to do, whatever I have control over, and you know, leave the rest in, you know, higher power's hands. I don't know what else to say except
No,
other people have come before me, and so I'm just coming along for the ride.
You're doing great.
Thanks.
Yeah, Len, I'm glad you brought Bob into that too.
By the way, I don't know if anybody mentioned this to RJ, but if you can get darolutamide, which is Nubeca, for your androgen receptor blocker, try and get that. It has the least side effects, particularly with regard to fatigue and brain fog.
Well, it does, Len, but I'm not certain that it gives you the most. In other words, the research still seems to say that abiraterone is better to start than darolutamide. I mean, darolutamide is not that much worse, but aren't I correct in saying that abiraterone is better, but it does have a worse side effect profile?
Better in the sense that if you become resistant to it, you'll probably have a greater likelihood of responding to a second ARPI. Yes, I agree with that.
Yeah. I mean, if you took two RBs together, any two, in any combination, the longest length of time to castrate resistance would be by starting with abiraterone.
I don't know. Have they ever done a head-to-head on that, or you're looking at?
Well, I mean, they've looked at abiraterone following enzalutamide versus enzalutamide following abiraterone.
Oh yeah, okay. So you're talking about the second.
So
yeah.
So I mean that, and again, that's a discussion for to have with Dr. Schweitzer. And the nice thing is, all those three doctors are all going to have very open discussions with you, and they're going to really put you into shared decision. Really, Matt, you have your hand up, and I know you relate to this pretty good too. Also, age-wise, you relate very well. And you're muted right now, so you have to unmute. There you go.
Yeah, I just you guys actually covered some of it, but just for RJ in particular, I mean, all the guys were in this chair, I guess, but man, it sounds to me like you just found out you were metastatic right in this meeting here in front of us. That's big news to take on, and I'm sure you're going through a lot of emotions, but you're in the right place, just like you said, like everybody told you. I heard you talking about your attitude. I've learned that that's the most important thing. So you're ahead a step of the game, and all the information you got today is insanely useful, and it pretty much blowed me away when I got it. It was too much. I couldn't hardly handle it. So if you're feeling that way, it's fine. These guys will answer emails. They'll answer your questions on the next meeting. You don't have to remember everything you learned tonight at all. There's plenty of resources and plenty of time to get this handled. And these guys all know way better than me, but and it sounds like you got a great doctor team, but you feel like you have to know everything right now, but you probably don't have to make any critical decisions. The doctor's going to give you some info, and you just always tell them, great, let me think about this, and come back to the group, and you can get some help. And yeah, you'll I was in your case, a little year ago. I think I'm so much not an expert on this, but Rick kind of touched on it. I think one of the things you just learned about kind of counting up the Mets, I think there's treatments if it's like over 5, or for some studies it's 3 or less. So it is important to figure out, kind of how many Mets you have, I assume at some point. But anyway, you're in the right place. I'm really sorry you got that news today here with us, but man, I was at work walking around and I about collapsed and had to go sit on a bench for like half an hour. I couldn't even stand up. So, yeah, you're a pretty brave dude. We got this.
Thanks, Matt. Yeah, I mean, I got an email on Friday that said, oh, like you have a new test result, and I looked at it and it was just the entry that they put the image in and nobody had taken a look at it, and I was kind of like, you know what, like I will wait till the right time and the right place when I do get the result. And it seems like this is the right time and the right place. So now I know, and I'm in good company and in good hands, and also we'll get the right doctors and get the right information and hopefully make the right decisions and do the best that I can with the hand that I've been dealt.
Yeah,
so
good luck, buddy. Yeah, for sure.
Make sure you exchange emails with Steve L. if you didn't do so already, because Steve really knows the ropes around Hutch, and so if you hit a sort of an administrative snag, or he may have dealt with it before, and he may save you a whole bunch of time. So guys, exchange emails in the chat, please.
Will do. Thanks. I've got Steve's number, so.
Okay, perfect. As long as you know how to get hold of him.
Gary, got your hand up? Oh, wait a
Yeah,
minute. Oh. Oh, yeah. Okay. I got the Garys mixed up again. Go ahead, Gary. San Francisco, Gary.
right. Um, First off, RJ, you're really just starting a journey, and I think you'll find that as it goes on, that there are a lot of things that are opening up for you. What I would like to do is find out how I can get information on this multidisciplinary group at Fred Hutchinson, or Fred Hutch, they call it. The reason being, I'm down here in San Francisco, and I'm in 3 other groups, all of which are local. And I would say that we don't have it, from what I understand, there's no such thing as that multidisciplinary group down here. The multidisciplinary group in San Francisco, I think, is Peter Carroll. He's the one doctor who has a reputation for really taking a broad approach to people who come into his office. But I'd like to find out, is there a website or something? Can I put my email in the chat? I don't know if I'm making myself clear.
Sure, you can. And if anyone can answer Gary's question about the group, please answer his email.
So I don't think there is necessarily an answer, Gary. I think that what you'll find is every National Cancer Center Network hospital and some of the NCI hospitals have different approaches, and some of them run multidisciplinary tumor boards that they invite their patients to, and others do not. So we can't say to you, this is where you'll find it. Yeah, we know that Washington does it. I'm trying to think who does it on the East Coast. There's a couple of places who do it. Your best bet would be to Google multidisciplinary tumor boards and see who's suggested. Usually, if they do it for one cancer, they'll do it for a whole bunch of different cancers. Is there anybody else in this group tonight who has been through a multidisciplinary board other than at Hutch? And just use the hand up feature to show us if you have, and we'll come ask you. It's the reason you haven't heard a lot about it is because a lot of hospitals don't do it, and some of them do. And frankly, I'm sort of in 2 minds about it, about the benefits, because I'd rather go see somebody who is I have to find a doctor who's very knowledgeable. Like I would rather go to a Dr. Singh, to a Dr. Schweitzer, and then go to a Dr. Lin, and then go to let me take UCSF. Go to Peter Carroll, then go to Mac Roach, then go to Agarwal. And rather than having them discuss in front of you, and then choose one of them to help you think it through. I don't know how well those tumor boards really serve the patient. They have their pros and they have their cons.
Without being an expert at all, I think that if you go to Mac Roach, he's going to tell you to get radiation. He doesn't have a reputation for being a multidisciplinary.
Okay, but let's not talk individuals.
Okay.
Let's talk, because it's too specific for most of the people that are in this group.
Yeah.
I mean, if you want somebody who's yes, Mac's going to tell you, go get radiation, but you know what you're going to get. Peter's going to tell you either or. But now we're talking a whole different situation. And this here, when we're talking about somebody who's metastatic, I don't want to talk about I don't think we should be talking about multi-tumor boards in this group. Now, maybe it's a good discussion to have in the low intermediate group, but in the high risk recurrent advanced group, I'm really not so sure. Although sometimes surgery is applicable for high risk guys, but I think it's the rare occasion, and it usually involves comorbidities.
Well, there's a lot of, leaving out surgery still leaves a lot of issues to be discussed. And
well, not really. Not really, because if RJ came in before,
yeah, you're right,
and he said, I've got Gleason 9, then the only issue then is, well, got a Gleason 9, should he have surgery or not? We would probably say no, because he's going to need hormone therapy anyway. And then the question is what type of, and we know what the gold standard is. The gold standard today is either Breaky or SBRT plus IMRT plus hormone therapy. And now, when he comes in showing more than 5 mets, then we know the protocol is start with chemotherapy. If he's got less than 5 mets, we know the protocol, and it's been shown in enough studies, is get hormone therapy plus a second-line anti-androgen, and then we'll see whether we want to come in and debulk. But you don't need these multi-tumor boards. They sound great, but to me, it's bells and whistles. Now, he's also got access to this group, and in a certain sense, we're a quasi multi-tumor board.
Okay, well, I brought up thank you. Let's let it go with this.
Okay. Alan, you have your hand up.
Yeah, I'm just wondering how it's possible to get email addresses from some of you guys.
Well, if you want them directly, go to the chat window and send a direct message to whoever you want it from. So okay. In the bottom, you'll see it says everyone, maybe on yours, and you click the down arrow and you can pick who you want it.
Okay.
If there's anybody that you don't find and you need some help, you can send me an email and I'd be happy to give it you. If there's anybody I'm not sure about, I will check with them first, but most of our guys I know pretty well. But the best way to do it whilst you're on the whilst you're on in the group is to just send them a request and say, can I reach out to you?
Okay, I appreciate that very much, Rick. Thank you very much.
Okay. Yeah. That goes for everybody.
Okay.
Now, Dr. John said he has to step away for a few minutes. You should be aware that Dr. John is wrestling with a nasty cold. Oh, is he coming back?
No, I'm going to go now. Joel is next, Rick.
Joe, thank you. Okay, Joel. Right, thank you. Joel, you're up.
Okay, thank you. Late April this year, I went to Houston and got a colonoscopy by Dr. Quigley. Dr. E wanted me to do so because she says all her patients go to Dr. Quigley for colonoscopy. He's an experienced doctor for the past 30 years, and he's retiring, as a matter of fact, in June or July of this year. Because I didn't have a partner with me or anybody with me, a friend with me, they said, well, we can't sedate you during your colonoscopy. It says, okay, well, go for it. And they did. And to my surprise, I enjoyed it. I saw everything that was going on, and I would even do it again if they asked me to do it without sedation. So it isn't that bad. They even found a polyp. I saw them cut the polyp out. I saw myself bleed inside, and they came out about 5 minutes later, and they said I was done. It took about an hour. The only thing I didn't expect, because I've already had 3 colonoscopies before this, but the only reason I'm taking this, I had to take this, is because I thought I was through with colonoscopies because I took one every 10 years for the last 30 years. And but Dr. E is convinced that my prostate cancer, my colon cancer gene is driving my prostate cancer. That's why she wants me to take a colonoscopy every couple of years. I thought, well, I forgot what I wanted to say, but anyway. I'm putting on my shoes at the end of the colonoscopy, and my phone rings. Didn't know who was calling me from Houston. It was Dr. E. She says, "You come in and see me at 1:20, right?" I said, "Yes." She said, "I'd like you to come earlier. Come at 1 instead." I said, "Okay, anytime, doctor. I'll be there whenever you say so." So I did see her, and she said she had never heard of anybody taking a colonoscopy before their whole career without an anesthetic. Anyway, she learned something that day, along with myself. So the reason she also ordered a Tempus report for me, which is the 3rd one in the last 6 months. She now says she's using the Tempus report as a PSA report. She says, for advanced prostate cancer patients, I am using the Tempus report as a PSA report. And she says, I've gotten baselines on you in November and February, and now we're going to take another one. So she sent a phlebotomist to my house a few weeks ago, and they drew my blood and they sent it to Tempus. So I'm going to have another Tempus test result soon. On the 26th of June, I see Dr. E again, but this time in a televisit. And she's having me take another PSMA PET and a chest CT because the last time I went to the Metro Region PET Center here in Annandale, Virginia, they said on the findings that I should have another chest CT in 6 months, since they couldn't tell what some of the nodules in my chest were. So I'm going to do that. So my question to any Dr. E patients, if we have some in the house tonight, have you ever heard of her saying that she's going to use the Tempus as a PSA?
No, I haven't, but I have a request from her for a Tempus test that I've got to take soon. So I'm glad to hear that, because I'm going to be meeting tomorrow with my local oncologist, and I know he's going to ask why in the world do the Tempus again. And so thank you, Joel. That's good news.
Yeah, she let it slip that she had lectured 1,000 surgeons in Las Vegas recently. And I went to my urologist about a week ago, and I says, yeah, my doc wants me to take a Tempus test every 3 months, and because she's using it as a PSA. And the doctor says, yeah, I heard of that. I just went to a conference. And so when we left the room, I asked his nurse where he had gone to for the conference. And she says, Las Vegas. Well, I said, well, now I know who told him that. So she referred to all the 1,000 urologists at the conference as surgeons, which they are. But that was her terminology. Any other questions or comments?
No, but I think this is a great conversation. It's one of the reasons why that it's one of the reasons why we love Dr. E. She's very thorough. Um, you're in great hands, and you know that. Jerry knows that. And do we have any other Dr. E patients in the house tonight? I guess not. We got a few. We got a couple who we would like to be Dr. E patients. We've got a few that we'd like to be sending to Dr. E. But Gary, yes, Gary, you're not a Dr. E patient, are you? No, go ahead, Gary.
I was just going to ask, how does the Tempus test replace a PSA?
Well,
okay, I can
go ahead. Go ahead, General.
I can answer that a little bit. The new Tempus test checks for 353 genes, I believe. If that's not accurate, it's very close to that number. And she's told me that like on the Tempus test, if I have 4 genes that show up, the worst one is the TP53, and it shows up 4 times. And she can tell by the percentages after the TP53 whether my cancer is progressing or regressing. And I believe that's how she's going to use it as a PSA. She did, in fact, tell me that. That's how she gauges whether or not your cancer is getting better or worse. So I assume that's what she's going to use, is a percentage after each of the genes identified by the Tempus test.
Is that the VAF you're talking about when you say percentage?
I don't know what the percentage is called, to be honest with you. Maybe Dr. John knows.
I think it's called variant allele frequency.
Okay. Yeah, no, I haven't been able to read a Tempus test accurately enough to make sense to me yet.
I think what she's saying, Gary, is that there's a lot of information in these tests, and the doctors who are really knowledgeable on reading these tests, what the DNA means, what the RNA means, what the percentages mean, and what have you, can draw a lot more out of these tests than where the mutation lies and if there's a drug that's appropriate, which is the very basic use of that test. That's why we run them, first of all. We want to know, does Joel have a new somatic mutation? Say, for example, he may have developed a somatic BRCA. Len developed a somatic BRCA for a while and then it went away. And if we see a somatic BRCA, then we say, oh, well, maybe it's worth putting this guy on a PARP inhibitor for a few months and see how he responds, even though he's not germline BRCA. So the very basic level is to look for the precision drugs. But there's a whole level beneath that, which I don't understand, with the RNA and with the proteomics and with the this and with the that. Len, you understand this better than I do. You can maybe explain a little bit. What is this like second level that we know he is using to tell us more?
Well, Joel, are you not producing much PSA? Maybe that's why she's searching for alternative means of monitoring your condition.
Well, ever since I've been on Orgovyx and darolutamide for the past 2.5 years or slightly more, I've 5 months into that treatment, I've been undetectable. So she has no PSA to go by other than undetectable. So I don't know. I don't know what's in her mind.
Well, so is there any evidence that while your PSA is undetectable, that your cancer is still progressing?
Not that I'm aware of. I think she's trying to stay one step ahead of the cancer, and that's why she's doing what she's doing. But I don't know exactly what her plan is.
How long have you been on the hormonal therapy?
2.5 years.
2.5 years. So, Rick, I'm thinking she's playing the game of, that Armstrong from, what was it, Duke, who said that something like 25% of cancers with undetectable PSA can still be radiographically progressing. So maybe that's just her way of trying to monitor things.
Yeah, and it occurs to me that the PSA isn't going to tell you much if you are undetectable. And this test is going to tell her a lot more about what else is going on. Now, it's a heck of a lot more expensive, that's for sure, but it also gives you a lot more information.
Yeah.
The one thing I was forgetting a while ago, and that is I was unprepared for. There's another technician that gets next to the doctor while he's doing the colonoscopy, and they maneuver your stomach. They actually grab your stomach and move it around to accommodate the doctor. The doctor told me that my intestines were a lot of curves in them, more so than the average. So they had to maneuver my stomach around while I was laying there, and that was uncomfortable because it hurt. But the camera and the probe did not hurt at all. I could feel it, but I don't. Maybe your colon doesn't have a lot of nerve endings in it. But I was not in pain because of that. But the guy. Now I verified that by my assistant leader of the prostate cancer group that I lead. He had the experience where he was under sedation, but he woke up and the same process was going on with him. So he verified that that's what they do. That's how a colonoscopy is given. They move your stomach around to help the doctor put the probe through your intestines.
Mm-hmm.
Oh, Joel, what was the result of the colonoscopy? Everything good?
Yeah, well, as I said, I saw them take one polyp out. And of course, I was talking to the doctor as he was doing it. They cut it out. I saw it bleed, and they'd sent it to the lab, and I was fine. I've had 3 colonoscopies before this, and the first one was negative. The last 2 before this one I had 1 polyp, which was negative for cancer. So I've had. Plus, I took a Cologuard test about a month ago, and that was negative for cancer also. I do have the MTUYH gene.
Yeah.
Can I say something?
Yes.
Take just a second. I had I don't know how you were able to endure the colonoscopy. They pump so much air up your rectum and your bowel in order to inflate it so they can see everything clearly when they want to snip off a polyp or get a good view of your. And I was courageous one time like you, the first time and never again. And I allowed so I could watch the scope at the same time. And when they started pumping that air up there, it was so painful. I said, shoot me up. I can't take it anymore. And I don't know how you did it. You're a good man, Joel. It's you didn't feel any pain and pressure when they pumped that air up there?
Well, I didn't feel any air going up, so maybe they did it differently. I'm not sure.
Maybe.
You liked it.
I didn't mind it if it was just that. Yes.
Okay.
Yeah, I've had one colonoscopy when they put me in the twilight zone so I could actually see what they were doing. It wasn't uncomfortable at all. So, I should just mention to you that Dr. John is not feeling well at all. and has taken the rest of the evening off, I think including veterans speaking freely. Be very surprised if he makes an appearance there. So Len and I will be capably finishing. If there's anybody in the room right now who either had their hand up and we haven't visited, or would like to say something right now, or would like to return to something, that discussion that we had earlier, please use the hand up function, and that way we'll know who it is. So the hand up function, in case you don't know, is that little hand at the bottom on the next to where it says recording on the left, on the right side of the recording. So okay, Don Rogers and Gary Peters will definitely be visiting with you momentarily. To get back to General Joel, anybody else have anything they want to know? Gary Peters, are you happy? This is not coming back to you on why you have your hand up. This is on your question about PSA.
Yes, thank you.
Okay. So will Joel, can we move up? Can we move on?
Yes, thank you very much. I appreciate the comments.
Okay. So we're going to go to Don and then to David M. and then we're going to go to Gary Peters. Mr. Rogers, you're up.
Yeah, we had a discussion earlier about whether or not cancer can spread during a biopsy. Same question, but does cancer spread as a result of a prostatectomy? I'm in another group, and there's a member of that group is convinced that his prostatectomy is the cause of his extensive cancer. What's the thought on that?
Well, now you ask after Dr. Schellhammer left, you know. Now you're asking. I think there are a number of answers. Let me take the low-hanging fruit. The low-hanging fruit is any respectable urologic oncologist would say absolutely not, because they would never in a million years want to be responsible for spreading cancer as a result of their bad work. And I have never, this is the first time anybody has ever raised that in all the years I've been doing this. I mean, I frankly cannot see it. I mean, we remove the gland with a margin exactly for that reason. Could you have not removed enough of a margin? You could have done, but it should show up on the post-operative pathology. I would need to hear where this guy thinks it's happened. I can't see it unless it's a really cack-handed urologist. I can't see it. I mean, if that's what he thinks happened and he's got reason to think, he probably has a malpractice suit. I mean, it seems to me that it's probably an unhappy customer who got unlucky. And remember, there's about 30% of people whose cancer returns. And it sounds like he's one of them. And I'm going to throw this one open for discussion. Anybody else have any different ideas? Len, start with you.
Well, I think that I'll just quote, I mean, I agree with you, Rick, but I'll quote Dr. Paul when he said, hey, anything can happen, right? We're talking about statistics here.
Yeah.
I wouldn't be surprised if, like he said, 1 in 10,000, 1 in 20,000 cases, maybe that happens, but it's highly more statistically probable that this person had micrometastases that didn't become manifest until sometime later. Yeah, that would be my answer.
This individual's point is that the prostatectomy actually injected micrometastases into his system. I had a discussion with my surgeon about this, and he says the way the procedure is done now, that the prostate is removed, is placed into a bag, some sort of a plastic bag inside the abdominal cavity, and removed that way to prevent any tissue from coming out as the prostate is removed. So I don't know what the answer is. I mean, there's got to be some science out there. This is not the first time this has been asked.
Well, there's also this phenomenon of epithelial to mesenchymal transition. So in other words, only certain cancer cells are even capable of escaping and their native environment and surviving in your system. And if they haven't gone through that transition of epithelial to mesenchymal transition, they're just going to die anyway, if any cells leaked out, you know? So it's like I said, it's highly, highly unlikely that that could be the cause of his. I don't know. Was he looking for a lawsuit? I don't.
No, he's
grasping at straws.
The gentleman's a nurse. I respect him a great deal. He's now fighting bladder cancer as a result. He caused as a result of his radiation treatments.
Well, I think, has he had any genomic testing?
I don't know. Don't know.
Well, that would be my first question, because I think he's looking for a reason why he's had these multiple cancers, and I'd be looking at the genomes. I mean, we have one guy we have one AnCan who has had bladder, kidney, and prostate cancer. Fortunately, all fairly mild, but it happens. But, you know, they're the sort of people that can say, can spread rumors. You know, I don't know. I don't know what to say. Anybody else have questions on this specific issue of spread from an RP?
Thank you.
Gary, I'm going to go to David first because you've already spoken tonight. Mr. Muslin hasn't spoken yet, and then we'll come to you, okay?
Thank you, Rick. The question is, how often should we be tested? How often should we do genomic testing?
Great test. Great question. So I'll give you my take, and then, you know, I'll ask Len, and then we'll throw it open. But just some history. So the genomic test was first approved, I believe, by Foundation Medicine around 2018 or 19. I'd have to go in and look at my notes. And when it was approved as a once-in-a-lifetime test. And we had already submitted our comments through Foundation Medicine, and others had. And we were very, very unhappy with that, as, of course, was Foundation Medicine. So we lobbied for probably about a year or two through I think 2020, at which point Medicare, who really is out front on all of these things, because Medicare makes the decision and then the other payers usually follow. And it was changed to as needed, determined by your doctor. So that allowed, and this is in the United States, and I'm sorry, because you guys can't even get one. Never mind bloody follow-ups. Good night, Frank. So we changed it, and ever since then, I think the system has worked pretty well. And a lot of times it's up to the doctor. And usually when they see a significant change, they will order a second test, and it invariably gets approved. Now, I haven't come across anybody else using a genomic test like Dr. E, but then I haven't come across anybody else like Dr. E, so that's probably the reason why. She is one of those doctors who can get what she orders approved in most cases. And I think that's the bigger issue. You need a doctor who can get approved what you want approved. You don't want somebody who's going to turn down Orgovix like we've been dealing with. She gets things approved first time. How does she do it? I don't know. What I don't think we can do is probably we can't get those tests approved within 6 months of each other. Joel, when was the last time she got a Tempus test for you? Did Joel leave?
Every 3 months.
Every 3 months.
Yes.
Well, I don't know how she does it, but she's doing it. So, but the idea is that the idea was when we lobbied for it was if there was a significant change in your status, David.
So should it be normal operating procedure? Should we just ask to get one? Would that help? If I'm going to go see Schwarz in a week and a half, should I ask him for one?
When was the last time you had one?
I would think in 2020.
Yes.
A long time ago.
Yes. Yeah, I think there's no harm. If you haven't had one for a long period of time, yes, I think you should.
Right, and everybody else should as well.
Yeah, I mean, if you haven't, would I say every 3 months? No, and most people aren't going to be able to get it. But I would say that, yeah, every few years, 2 or 3 years at least, you want to know whether your body's done something different or how it's responded to the cancer, even though you're in a great situation and you're stable. There's nothing wrong with getting it. Len, what's your thoughts on this?
I guess the only thing I would add is a factor that the doctor could use to persuade insurance to cover is if they would say, well, I have this guy, his PSA is undetectable, but he's feeling really crappy. He's really tired. You'd have to have some clinical symptoms. Maybe you're feeling some pain, and that might be persuasive for the insurance company to cover it. I was just wondering, Joe, is he still with us? Joel? Or is he gone?
Yes, what's the question?
Oh, so the question is, are you paying for those every 3 month genetic tests, or is it being covered by your insurance? And if by insurance, do you have like super good insurance?
No, I'm not paying for anything, and my insurance is Medicare and TRICARE.
All right. I don't know, is TRICARE like a super military health benefit? Yeah.
TRICARE for life, yeah.
Yeah, so that could be a factor too. If you have really good insurance, I guess they'll cover it.
I mean, TRICARE's a good payer. I think there are some payers out there who might quarrel with every 3 months. I think most of them are going to pay every 6 months if your disease is moving. And I think most of them will pay if you're metastatic and you haven't had a test for 4 or 5 years, they're going to pay.
When I was under Anton Arakis as my GU medical oncologist, the first he met me, and 5 minutes later he was ordering a foundation medicine test for me because I never had a genetic test before. I'd already had a germline test, but not a genetic test. And back then, T53 and P10 came out. P10 has never been on any of my other exams, any other tests, only TP53. So I assume that P10 has dropped out. And so your genes do, as Rick said a while ago, your genes do change on these tests.
They do, don't they, Len?
Yep.
Hey, this is Jim Ward, if I can jump in with a question.
Yes, Jim Ward.
So I did get genetic testing when I was first diagnosed back in late 2018. I haven't had any genomic testing since. I had some somatic testing, done a couple of years later. But in terms of the genomic, what do we think is the best genomic test? I know Foundation Medicine is one that we talk about a lot. Tempus, of course, we've been talking about quite a bit tonight. But is there one that stands kind of above the rest?
Well, I don't understand them that well, so I may not be the best person, but if it was me, I probably would be asking for Boston Gene, because it seems like technically they're ahead of everybody else. And they are also incorporating some AI into their test results, but I can't really tell you. If you're really interested, you can get on an airplane, you can go to ASCO, and you can go around and you can ask each one of them to hear their sales pitch as to which one is the best. I don't know. Len, what do you think?
Oh, you know more about that than I do, Rick. I'm not really sure which one is best.
Well,
anyone else have anything they want to contribute to Jim on the different providers of these genomic tests? Okay, Jim, what were you going to say?
Oh, yeah, sorry. Thank you for kind of polling around the room. I know I'm at a little bit of a disadvantage being on the phone. Well, and I'm embarrassed to say I can't remember which outfit did my genomic testing out of the gate. If I thought about it, it would come back to me, or if I started pawing through my files. But it certainly, this conversation's kind of inspired me to ask for another round of genomic testing. And obviously, I guess Dr. Korn might have his favorite. But gosh, I thought that it was kind of a one and done thing. You got your so-called germline test done early in your early after you're diagnosed. At least that you hope that the doctor would think to do that. And fortunately, my oncologist did, my local oncologist. But I never imagined that you would get it done, at any point subsequently. So this is kind of an eye opener for me.
Well, I mean, I don't want to mislead you. I think that if your disease has been very stable since you came off of your treatment, there may not be a reason to do it. And maybe Dr. Korn will say you don't need it. But if your disease has been changing and you've gone on IHT, then you've come off, if you've gone on intermittent, and then you've had to go back on treatment, and then you've gone on intermittent again, if there's been change in your treatment, then yes, I think there's good reason. But if your treatment stopped and nothing's changed since then, I don't think there is good reason. I mean, David's treatment has changed a little bit, and he's been on 2 or 3 different treatments, and he's had to manage his treatment. In your case, thank God, nothing has happened since you came off the treatment, so it may not be necessary. But
that's a good point. That's a great point, Rick. So I think no harm in kind of teeing up this subject and seeing what Dr. Korn has to say, and I'll share. I'll certainly share with the group. I see him in August, just as a part of kind of an annual trek to MD Anderson. I'm going to ask him about it. So I'll share with you guys whatever he has to say about it. But just very interesting.
Right, and the reason the somatic changes is largely in response to treatment, because the cancer is consistently trying to find a workaround, and part of that cancer trying to find the workaround is the gene mutations occurring. So, like in Len's case, where when his treatment was pretty aggressive, he made a BRCA mutation, and then as it settled down and he started to do fine and he stabilized, the BRCA mutation went away, but they were always somatic.
All right, fascinating stuff. Well, thanks for kicking this around a little bit.
Okay, and I'm just going to give any vets still on the call a quick heads up that your meeting starts in 5 minutes. A lot of the vets have already left already. General, if you're going to go to vets speaking freely, it starts in 5 minutes in the Schmier room. Okay, let's go to Gary.
I just wanted to earn a little extra respect from Dr. Jack. I've also had a colonoscopy with no sedation. And my advice is only try it with a very experienced practitioner. Joel had an experienced practitioner, so did I.
Okay.
But did you like it like Joel?
No, thank you.
We may have to create a new group for Joel to lead, for people who enjoy colonoscopies. I can't say I ever enjoyed it, but I will say that doing it with a twilight anesthetic didn't bother me at all. I will say you that. It wasn't a bad experience, except I was busy watching, and the next thing I'd fallen asleep, and when I woke up, I'd missed it. I missed the show.
Once you get propofol, you can never go back.
Okay.
I mean, it's so simple, complicated. 1 minute your eyes are open, next minute you're, ready to go home. It's just with no hangover or anything. It's wonderful.
You talking about propofol?
Yeah.
Yeah. It's no wonder Michael Jackson wanted it every night.
Right.
Gary's lips are sealed. He's not answering the question either.
I wrote a poem about propofol. Slow dose of propofol injected in my vein, the slowly rolling snowball targeting my brain. The cool flow of sedative climbs up my arm into my shoulder. I'm suddenly alarmed. With one final thought just before I fade, where will I wake? Where will I wake?
Very good.
Bravo.
You may have given Ben a real problem, because the editor's pick before this was certainly going to be R.J. Smith, certainly. But now Ben's going to have to decide, is he going to go for propofol or is he going to go for R.J.? Well, I shouldn't say certainly, because it's Ben's pick, it's not mine. Oh, wait a minute, maybe it is mine. I think Ben's away. I think I'm supposed to write this up tomorrow. So now I have a problem.
Are you a writer, John? That was very creative.
Yes, we like that. Okay. Well, it was a slightly smaller group. Jimmy, you sure you don't want to say anything, Jimmy?
Sure, I'll always say something.
Well, go ahead then, quick.
Well, I'll tell you what. Michael Jackson did meet his demise from propofol, because even liquid Valium wasn't good enough for him. But before they had the propofol, I think, is when I had a shoulder surgery, and they gave me the anesthetic, and I got out of the surgery. They put me in the rubber room with all the other people coming out of it in case there was any strange behavior. And I had strange behavior. I came out and I started ranting and raving that they didn't know who I was. And I said, what? I said, I'm James Taylor. Fire and Rain? Have you ever heard of Fire and Rain? I was cussing at them. I was outraged that they didn't know who I was. They wheeled me out and got me calmed down, and my first wife came and picked me up. And she said, how are you doing, honey? And I said, I'm doing fine. And they started bawling and took me home. So I think they've made some great stride with the pharmaceuticals, because I've had the propofol too. And the propofol is indeed short acting and beautiful.
Jimmy, what was the drug you were talking about where you thought you were James Taylor?
Well, that was earlier in my life. I think it was before propofol, either before it was used or before it was commonly used as a general anesthetic. So whatever they used to use before was a little bit dicier. You know, people used to have problems and sometimes die in surgery because also the nerve block affected it. You know, before they had nerve block, they had to really go out. Now, Jack, can you testify to this? Before nerve block, they had to really be delicate with the anesthesia because the pain would wake people up and they'd have to put them back under again. And it was tricky, right?
I'm pretty sure they used fentanyl before propofol. Sorry, Jack.
Yeah, tell us.
There was a time before
we'll never know.
fentanyl. I'm old enough to remember it, and they had all kinds of idiosyncratic reactions back when I was in school back in the 60s. So horrible anesthesia deaths.
You say you're not old enough to remember? Well, we know nothing.
That's on the other side of his brain.
Anyway, that's all. Yeah.
All right.
Good
night, everybody. Well, listen, if anyone else to say anything or otherwise, we're closing the room at an early time, 8 o'clock. That's very good.
All right, let's watch the basketball game.
Go Cubbies.
Go Knicks.
Good night, everybody.
Bye-bye.
Good night.
Good night. Good night.
Thank you, Rick.